Okay, so let's pick up with the last section of your part 1 of our cardiac materials for this week. Now, you'll have to review this video. Remember that you have your blog due, and that's due Saturday at midnight. Now, to treat essential hypertension, we're going to talk about the approaches that we use as far as how we go about the different medications and knowing when to use which ones. But to recap, essential hypertension refers to the type of hypertension that is the majority of cases. So most people who have high blood pressure, 90 to 95% of them have essential hypertension, right? And it means that we don't know an underlying cause. They just have it for whatever reason. All right, so to treat it, we're going to use a stepwise approach, which means we try and go least invasive to most invasive. So first off, we try and change those lifestyle things that are modifiable. So modifiable means that we can impact them, we can change them. Non-modifiable are things that we cannot change or influence. So modifiable risk factors are things like diet, exercise, right, physical activity. Non-modifiable things are the ones like genetic history, race, age, right? We can't change how old somebody is, but we can change whether or not they drink alcohol. So the first thing we're going to do in our first step is change modifiable risk factors and working with patients to do so. Then we go to pharmacological agents or medications, in other words. We're going to use diuretics. That is going to help them to increase their urinary frequency so that we pull off extra fluid, right? We're going to have the adrenergic receptor blockers, ACE inhibitors, other receptor, or the A2 receptor blockers, and vasodilators. So our inhibitors and blockers are targeted at helping the heart to beat properly, right? And vasodilators are going to open up your blood vessels to help decrease the blood pressure. All right, so first step, modifiable risk factors. All right, if we do that and we still don't have a good blood pressure, so one less than 140/90, all right, or if they have diabetes or kidney disease, we don't even want it that high, all right? Then we go on to picking medications, all right? So we try lifestyle changes, we come back, we recheck their blood pressure, it's still high, all right, now we have to give you drugs, all right? So if they don't have compelling factors, that means they don't have any of those diseases that go along with hypertension that's untreated, right? That's things like stroke, cardiovascular disease, right? Things like that. If they don't have those, that's without compelling indications, right? So if there's type or stage 1, meaning they're between 140 and 159 systolic, or, remember it's or, so if either one's wrong, we have to treat them, or their diastolic is between 90 to 95, we're going to try a diuretic first. We may consider giving them those inhibitors or those beta or those blocker agents. We would probably try a diuretic first and then come back and check it. Still no good, we'll give them the blockers too. Right? If they're stage 2 and they don't have disease, so we're still in the white box with the yellow letters here, right? One in the middle. So meaning their systolic is greater than 160 and a diastolic is greater than 100, we're going to do a combo. All right, so they get a diuretic and they get an ACE inhibitor or blocking agent. Now, if they have compelling indicators, meaning that they have hypertension as well as some type of disease that goes on because of that hypertension, all right, they have to have antihypertensive medications. All right, so they're going to get diuretics, ACE inhibitors, and beta blockers. All right, so we're going to do that for a while. We're going to have them come back, and we're going to recheck their blood pressure. If their blood pressure is still not good after medications, lifestyle changes, then we're going to look at increasing the dosages of those medications. We may add additional medications on top of that, right? And then we're going to see if they need to go consult a specialist who treats just hypertension and knows a lot about it. So secondary hypertension, right, is going to be hypertension that you get because there's another disease causing it. All right, so something else is going on, and we can relate the hypertension to that specific problem, right? If we treat the underlying disease, then we treat the hypertension and it goes away. right? So only about 5 to 10% of cases are actually secondary, right? Of those, things that cause secondary hypertension are things that impact the kidneys, right? So renal failure, you don't have enough blood flow to your kidneys, right? You have the wrong type of stimulation of your renin, angiotensin, aldosterone system, right? Things that are going to impact the kidneys, because your kidneys, remember, regulate your fluid balance, right? They're going to make you hold on to fluid, right? They're going to cause vasoconstriction if they're off, right? And that is going to indicate an increase in blood pressure, right? Adrenal cortico disorders, so things that stimulate your adrenal glands, right, or make them release corticosteroids, right? Things like overproduction of aldosterone and Cushing's syndrome, right? Your adrenals make you stimulate like your epinephrine, right, your adrenal system, right? So if you stimulate it, either because of disease or problems with your aldosterone hormone, you're going to cause stimulation to your nervous system. That will cause vasoconstriction and your blood pressure to go up. Pheochromocytoma is a tumor on the adrenal gland. So it essentially does the same deal as the above one, right? So the tumor on the adrenal glands makes them over-secrete epinephrine and norepinephrine so that it triggers that fight and flight kind of response, so that adrenaline release, and causes the blood pressure and heart rate to go up and stay that way. We also have hypertension that can go on across the lifespan. So we typically think about our middle-aged adults, the ones who might be obese or drink or smoke or have a family history, but there's other certain populations in our lifespan that we need to consider. So things like pregnancy. When women are pregnant, about 10% of all women who are pregnant can end up with pregnancy-induced hypertension. So what that means is that they didn't have hypertension before they were pregnant, right? But what happens is that because they're pregnant, it's causing hypertension, right? Their body is responding in a negative way and their blood pressure is going up, right? It's the second leading cause of death in moms, right? So maternal mortality. That's what that means. As women get older, and the older they are when they get pregnant, they're at increased risk. And African American women are also at increased risk. Right? It was called gestational hypertension. It's also called pregnancy-induced hypertension. Right? What happens is if you don't treat the hypertension, these women can get preeclampsia and eclampsia. So this is a serious complication that women can get from pregnancy-induced hypertension. And what happens is that in preeclampsia, right, they have hypertension, and then the hypertension damages the kidneys. All right. If it progresses, right, because of the hypertension, the kidney disorder, you have an electrolyte imbalance, we have fluid retention, right, we have all kinds of those complications that go along with those, like we talked about in your fluid and electrolyte lecture. It will progress to eclampsia. And eclampsia, what happens is the blood pressure gets so high that they have a risk of a stroke, an aneurysm, and seizure. And that's how, if we don't treat hypertension in pregnant women, they can end up dying from it. Right? The only way to treat preeclampsia and eclampsia is to deliver the baby. Right? We can treat gestational hypertension with medications, and we would follow that mom very closely. She'd be going in for regular visits and medication adjustments. Right? We can give her magnesium sulfate, which is a medication to help prevent seizures. Right? But if she actually gets to preeclampsia and definitely eclampsia, they will have to consider doing a preterm delivery of the baby. Right? In children, secondary hypertension is the most common form of hypertension. Right? So they don't usually get essential hypertension, right, until they're like an adolescent. And as we've seen a surge of childhood obesity and decreased activity in adolescent children, we've seen a surge of essential hypertension. Secondary hypertension is most common in infants and young children, and usually it's related to things like cardiac birth defects. Elderly clients, as part of our aging process, when we get older, your arteries get stiffer, right? Which means they don't constrict and they don't dilate. So we have an increased pressure in your artery system, which increases your blood pressure. All right, there are baroreceptors, So those things that sense pressure changes in the body are also less effective, all right? They decrease in their sensitivity as we get older, all right? So they don't sense when the blood pressure is already high to trigger the release of your sympathetic nervous system to help calm you down, right? Or to bring the blood pressure down, right? And also their renal blood flow is less as we get older, which can impact the body's ability to retain or release fluid. All right, so if you have any questions on those ones, feel free to call or email me anytime. You can also speak to the tutors. Now remember that we have tutoring available through the RISE Center, and the list for those tutors is in your Blackboard course if you need them. And there's also tutoring available at the Center for Student Success as well if you ever need to have time with them.